Hello, my name is Kyle Fitzgerald. I am a senior sRNA at VCU. Today I will be presenting findings from my literature review titled An Evidence-Based Comparison of Sugammadex versus Neostigmine for the Reversal of Neuromuscular Blockade in the Pediatric Population. At the completion of this presentation, the learner will be able to describe the general mechanism of action, risks, contraindications, and overall anesthetic implications of Sugammadex and Neostigmine, understand efficacy and safety findings in the current body of literature, and also recognize pediatric-specific conditions, including comorbidities and developmental states that convey altered pharmacologic behavior, increased risk, or increased benefit with Sugammadex and/or Neostigmine. A quick disclaimer. This review was undertaken with the purpose of clarifying the pediatric-specific implications of Neostigmine and Sugammadex to educate fellow students and CRNAs. This was done in part because Sugammadex was not FDA approved. However, since beginning this project in the spring, Sugammadex received approval for use in children aged 2 to 17 years old. This approval followed completion of a post-marketing trial evaluating safety and effectiveness of Sugammadex versus Neostigmine. Dosing recommendations are the same as adult dosing. Diluting to 10 milligrams per milliliter is recommended to ensure accurate dosing in smaller patients. For patients less than 2 years old, there is a second trial that is currently recruiting. Rocuronium. Non-depolarizing agents are similar in structure to endogenous acetylcholine due to presence of quaternary ammonium groups. These drugs are allosterically similar to acetylcholine, which allows them to fit and bind to nicotinic acetylcholine receptors. Binding to these receptors blocks acetylcholine function, and because these drugs have no inherent activity at nicotinic receptors, no depolarization occurs. The drug just takes up space, blocking acetylcholine from binding. Contraindications are listed. Also, due to metabolism of this drug, which is 70% hepatic and 30% renal, use with hepatic dysfunction may prolong duration. Rocuronium is of an intermediate duration and is used most often for intraoperative relaxation. Reversal is usually needed for safe emergence because of its duration and occupancy within the neuromuscular junction. Approximately 70 to 80% occupancy is needed for neuromuscular conduction to fail. Rocuronium can be antagonized with Neostigmine or Sugammadex. Neostigmine. Neostigmine indirectly antagonizes the effects of rocuronium through inhibition of acetylcholinesterase. This is the enzyme that breaks down acetylcholine at the neuromuscular junction. By inhibiting breakdown, more acetylcholine is available to bind with nicotinic receptors, and muscular function returns. Neostigmine increases acetylcholine systemically, though, not only at the neuromuscular junction. Muscarinic and nicotinic receptors at many sites may activate, simulating a parasympathetic response that is responsible for many side effects. It should be noted that such a response can be severe, especially airway reactions and bradycardia. Increased muscle weakness can include respiratory muscles. Very high doses can precipitate a cholinergic crisis as well. Anticholinergics, typically glycopyrrolate and less often atropine, are co-administered to combat these side effects. Dosing is guided by neuromuscular monitoring. A major drawback of Neostigmine is the ceiling effect at the neuromuscular junction that occurs at concentrations needed for relaxation. Because of this ceiling effect, deeper levels of blockade cannot be reversed. Administration is only recommended if there are at least 2 twitches with train of 4. Pharmacokinetics can vary in each patient, complicating timing for emergence. Neostigmine is associated with residual paralysis and recurarization, especially with longer-acting muscle relaxants. This occurs because paralytic drug is still present after Neostigmine is active. As Neostigmine is metabolized, blockade can return. Sugammadex is the newer option for reversal of rocuronium and vecuronium. In contrast to the indirect mechanism of Neostigmine, Sugammadex acts directly by encapsulating the molecules of paralytic drug and sequestering them away from neuromuscular junctions. The structure of this drug forms a donut shape, with negative charges facing outward and a lipophilic core. This is where paralytic agent binds. The orientation of charges results in a water-soluble complex that can stably bind relatively lipophilic paralytic molecules on the interior. Water solubility helps sequester the muscle relaxant molecules in central compartments, away from sites of action, prior to renal excretion. Elimination half-time is 2 hours, with 90% excreted in 24 hours. It is not metabolized. Most tolerate Sugammadex without adverse effects. The mechanisms responsible for hypersensitivity reactions are not understood, but they do seem to be dose-dependent. Hormonal birth control is inactivated by Sugammadex. In patients with renal insufficiency, the package insert cautions against Sugammadex administration. Pharmacokinetics are predictable and onset is fast. It is efficacious at reversing profound blockade, as in cannot intubate, cannot ventilate situations immediately after induction with rocuronium. There are several specific concerns related to neuromuscular blockade and its reversal for pediatric patients. Developmentally, especially in those younger than 2, altered respiratory mechanics may predispose children to postoperative respiratory complications. These patients are belly breathers, obligate nasal breathers. They have compliant chests and smaller airways that can collapse. Their respiratory rates are faster and they have a lower FRC. Suboptimal respiratory mechanics may increase the risk of postoperative morbidity in this population. In addition, children may present with syndromes associated with difficult airway or may have unrecognized difficult airways. Rapid reversal of neuromuscular blockade and return to spontaneous ventilation may be life-saving. Across the developmental span, from birth to 17 years old, this group is very diverse physiologically. There are many comorbidities in this group that may predispose the patient to increased risk. Things such as asthma, reactive airways due to smoke exposure in the home or recent upper respiratory infection, congenital heart disease, diabetes, various neuromuscular disorders and syndromes, abnormalities from prematurity, and more. Sugammadex was not approved for pediatrics in 2015 when it was initially approved for adults. The major concerns cited by the FDA was hypersensitivity and anaphylactic reactions. The reported incidence rates vary widely in published studies, and the mechanism remains unknown. With neostigmine, on the other hand, cholinergic effects are especially problematic for neonates and infants, especially bradycardia, because cardiac output is heart rate dependent in these patients. They are also prone to bronchospasm. Finally, neostigmine's limited efficacy may result in residual paralysis, impaired ventilation, desaturation, and aspiration. For this project, I performed a literature review to compare neostigmine and Sugammadex on the basis of efficacy, safety, and pediatric-specific conditions that may affect risk or pharmacologic behavior. Studies were sought that reported outcome variables including time to extubation, time for return of train of 4 ratio to 90%, out of room time, incidence rates of adverse effects, and reports associated with administration to patients with any pediatric-specific conditions. Only published studies were included. The very first study to explore Sugammadex use in pediatric patients was Cloud et al. This was a Phase 3A clinical trial conducted as a part of Sugammadex's initial application for FDA approval. Dose-response relationships, time for recovery of neuromuscular function, and adverse effects were outcome variables. Pharmacokinetic models showed identical dose-response and plasma concentration relationships among all participants, indicating similar dosing needed for pediatric and adult patients. Recovery was fast at 0.6, 1.2, and 1.1 minutes for infants, children, and adolescents, respectively. There were no differences in adverse effects among any age group. A search of the literature yielded 2 meta-analyses, the first of which, by Juan et al., included 4 randomized controlled trials and 2 unpublished abstracts. 5 of these studies utilized neostigmine controls, while 1 utilized placebo. In all, 253 patients were analyzed. The primary endpoint was time for return of train of 4 ratio to 90%, which was significantly faster in Sugammadex groups, with weighted mean differences of negative 7.15 and negative 17.32 depending on dosage. Secondary endpoints included extubation time and adverse effects. Extubation time was found to be shorter with Sugammadex. For adverse effects, there were no significant differences between Sugammadex and Neostigmine groups. The major limitation was high heterogeneity, indicated by the I-squared value. For reference, low heterogeneity is considered 25% or less, and moderate, 50% or less. Among the included studies, protocol and design differed on many levels, such as dosing of reversal agent, timing of reversal administration, level of blockade when reversal was given, anesthetic type, including use of volatile gas, and also age differences between the pediatric participants. In a second meta-analysis, 6 randomized controlled trials and 4 unpublished posters were analyzed. This study includes 580 patients in all. Neostigmine was the primary control, but like before, one study utilized a placebo. Return of train of 4 ratio to 90% was found to be significantly faster with Sugammadex. Heterogeneity was high for similar reasons described under the first meta-analysis related to differences in study protocols and design. For adverse effects, the incidence of bradycardia was significantly less likely in those who received Sugammadex, but the incidence of all other adverse effects were similar between groups. This literature review included 2 meta-analyses, and for both, heterogeneity was the major limitation. Also for both, published and unpublished studies were included, and many details for the unpublished studies, such as use of volatile gas, or TIVA, or the type of surgery, were not available. Finally, many of the included studies in both meta-analyses were determined to have unclear or high risk of bias. 4 randomized controlled trials were identified comparing Neostigmine and Sugammadex in pediatric patients. Some details related to study design, dosing protocols, population characteristics, and results are listed here in this table. The primary endpoint for each study was time for train of 4 ratio to reach 90%. Other outcomes of interest included extubation time and adverse effects. Results of each study showed significantly faster return of train of 4 ratio to 90% with Sugammadex. Also, extubation times were faster with Sugammadex, and this was also significant. For adverse effects, in the studies by Ozgun and Gonim, there were no significant differences in any adverse effects between Sugammadex and Neostigmine groups. However, the study by Amar found significantly higher rates of PONV, tachycardia, and dry mouth in patients receiving Neostigmine plus the anticholinergic. It should be noted that each of these studies had various limitations, including lack of blinding, missing information, ill-defined protocols, typos, etc. They were not of the highest quality. A major benefit of Sugammadex is efficacy in reversing deep neuromuscular blockade. Each of the studies listed here show effective reversal of deep blockade with Sugammadex. On the right are 3 case reports, and on the left are 2 observational studies. In the study by Osmet, infants undergoing procedures such as shunts, spinal fusions, external drains, and meningomyelocell repairs were given 3 mg per kg of Sugammadex at the end of surgery when the train of 4 was still 0 out of 4. All 26 infants were successfully reversed, and the mean time for a return of train of 4 ratio to 90% was 112 seconds. In the study by Matsui, patients received 0.6 mg per kg doses of rocuronium and identical anesthetics. Either 1, 2, or 4 mg per kg doses of Sugammadex were given. Most were successfully reversed. However, 3 patients in the 1 mg per kg group did display residual paralysis. Time to train of 4 to reach 90% as listed. Hypersensitivity and anaphylaxis were cited as the primary concerns of the FDA in 2015 when Sugammadex approval was delayed for pediatric patients. The initial incidence rate was thought to be 1 in 300. With more publications analyzing this, the incidence is likely lower than initially thought. However, no one really knows what that rate is. The values vary widely in the literature, which is relatively lacking in high-powered studies. Case-controlled studies and case reports predominate on this topic. Another issue is that from paper to paper, the criteria for hypersensitivity vary. Not all studies utilize guidelines in defining cases of hypersensitivity, and not all cases are confirmed. Published criteria, such as Sampson criteria or those from the World Allergy Organization, ensure there are no false positives. These guidelines are more thorough and consider the timing of anaphylaxis onset, skin and mucosal changes, cardiopulmonary function, and some degree of confirmation testing. What does seem to be clear, though, is that larger doses are correlated with a greater risk of a reaction. Also, true reactions typically occur within a few minutes of administration. Finally, presensitization could play a role, as cyclodextrins are present in many types of everyday products. 2 studies were identified specifically focusing on hypersensitivity and anaphylaxis as outcome variables in pediatric patients. Tadokoro et al. Found no significant association between Sugammadex administration and anaphylaxis. This study analyzed 835,405 pediatric patients who underwent general anesthesia. It found that 149 suffered anaphylactic shock following Sugammadex administration, and 472 displayed some signs or symptoms of a hypersensitivity reaction. Perioperative anaphylaxis was only found to be associated with duration of anesthesia and blood transfusions. World allergy criteria were utilized. In the second study listed on this slide by Gaver et al., patients younger than 17 who received Sugammadex were matched with Neostigmine controls. The incidence of anaphylaxis was identical between Sugammadex and Neostigmine. Also of mention, there were no reports of hypersensitivity or anaphylaxis reported within any trial, meta-analysis, or prospective study included in this literature review. Bradycardia is a concern for both drugs. Merck's package insert for Sugammadex reports rates of bradycardia as high as 10% in children. They warn it can be severe and lead to cardiac arrest. Neostigmine, on the other hand, stimulates a parasympathetic response, and it must be administered with an anticholinergic to combat this. Bradycardia is especially concerning in younger pediatric patients because cardiac output is heart rate driven. 3 studies are listed on this slide. In the first, by Tobias et al., 221 pediatric patients were analyzed. This was a prospective observational study, and 18 episodes of self-limiting bradycardia were reported. However, the big confounding factor is that out of those 18 episodes, 7 of the patients had congenital heart disease. Males were determined to be at higher risk. This group did a follow-up study analyzing the association of congenital heart diseases and bradycardia with Sugammadex. Gaver et al. And Liu et al. Found lower incidence of bradycardia with Sugammadex when compared with Neostigmine. In other studies already covered, including the randomized controlled trials and meta-analyses, there were no significant differences in the incidence of bradycardia between Sugammadex and Neostigmine groups. One study by Amar et al., which was a randomized controlled trial, found significantly higher rates of tachycardia associated with Neostigmine. The final segment of this literature review is to examine the pediatric-specific conditions, including comorbidities and developmental states, where either of these drugs may exhibit altered pharmacological behavior or pose increased risk or benefit to the patient. For neuromuscular disorders, specific concerns related to neuromuscular blockade and reversal depend on the particular disorder. However, generally speaking, there are concerns with postoperative weakness, respiratory insufficiency, exacerbations of disease, prolonged blockade, recurarization, and altered sensitivity to paralytic agents. The literature specific to pediatric patients with comorbid neuromuscular disorders is limited to anecdotal reports. Several case reports were identified and are presented here and on the next slide. These describe Sugammadex administration to patients of various ages with Duchenne's muscular dystrophy, myasthenia gravis, and myotonic dystrophy. For all cases, reversal of paralysis was effective, no adverse effects were reported, and recovery was uneventful. Another consideration for Sugammadex is renal insufficiency. According to the package insert, administration is not recommended with severe disease. This is due to increased excretion time. The efficacy of reversal is not affected. The concern is exposure to Sugammadex as it remains in the body for longer periods. Carlos et al. Reported 2 cases, a 7-year-old and a 14-year-old undergoing renal transplantation. The 7-year-old received a total of 42.7 milligrams of rocuronium, and the 14-year-old received a total of 121 milligrams of rocuronium. Reversal of Sugammadex occurred approximately 1 hour after unclamping and was uneventful. The authors postulated that improving renal function following transplantation and unclamping would allow for adequate excretion. Creatinine clearance was improving at 24 hours in both patients. Other than this study, which is not your typical study on renal insufficiency, no other pediatric-specific publications were identified on this topic. Considerations for patients with congenital heart defects and transplanted hearts. In a follow-up to an initial study on heart rate changes with Sugammadex, which was presented on slide 16, Tobias et al. Sought to evaluate heart rate changes following Sugammadex in patients with various congenital heart defects, valvular issues, and more. 99 patients were evaluated in all. Bradycardia was noted in 20 patients. However, 7 were previously bradycardic, and bradycardia was mild. It did not require treatment and was self-limiting. No association could be established between the risk of bradycardia and any specific diagnosis. The authors noted that there were no controls in place for both the anesthetic technique and Sugammadex dosing, and this may have contributed to higher rates of bradycardia than what is generally observed. There was also no control group for comparison, as this study was purely observational. To the right of the slide are 2 case reports describing Sugammadex administration to pediatric patients who were status post-heart transplant. Both describe successful reversal with Sugammadex and no complications. It should be noted that in patients who are status post-heart transplant, Neostigmine has been shown to cause drops in heart rate, even sinus arrest. This occurs due to variable parasympathetic reinnervation of the transplanted heart. As reported earlier, the FDA approved Sugammadex for 2 to 17-year-olds following completion of this clinical trial. It is not published yet, but data is available on clinicaltrials.gov. Inclusion criteria for this literature review included being published. As such, this study was not included in the manuscript. However, I thought I would briefly review the results here. The results apply to children between 2 and 17 years old. For dosing, adult dosing parameters are appropriate, with 2 mg per kilogram and 4 mg per kilogram dosing recommended for moderate and deep levels of blockade, respectively. For efficacy, Sugammadex was significantly faster at reversing moderate levels of neuromuscular blockade at 2 mg per kilogram doses. It was also effective at reversing deep levels of blockade at 4 mg per kilogram doses. Times for the return of the train-to-4 ratio to 90% are listed on the slide. For safety and adverse effects, there were no significant differences in adverse effects between all groups. And lastly, 16 mg per kilogram doses were not evaluated. The goal of this literature review was to integrate findings from the body of pediatric-specific literature relating to Sugammadex and Neostigmine, and educate anesthesia providers and students on the different implications when considering these drugs. The body of pediatric-specific studies is very limited, especially for patients less than 2. Also, it is saturated with anecdotal reports, small populations, retrospective studies, and other low-powered study designs. However, when taken as a whole, the use of Sugammadex in the pediatric population seems to be a safe option, and it is clearly superior in efficacy. For children younger than 2, this is also likely true, but the volume of evidence is so small for this group. More data is needed to be certain. To summarize findings from this review, Sugammadex was shown to be superior in efficacy and is efficacious in reversing deeper levels of neuromuscular blockade. Most differences regarding adverse events were insignificant. For bradycardia, several studies did report significantly higher rates with neostigmine. Valvular disorders, congenital heart defects, cardiomyopathy, etc. could be risk factors for bradycardia, but more studies are needed, as the one study examining this was flawed on several levels. Regarding hypersensitivity, we need more information. The current studies vary widely in terms of incidence. More studies are needed to clarify the incidence and the mechanism. For neuromuscular disorders, Sugammadex offers a lot of advantages and does not directly affect the neuromuscular junction as acetylcholinesterase drugs do. However, there are only case reports available currently for pediatric patients. In addition, Sugammadex likely offers advantages in heart transplant patients. This is because neostigmine is thought to stimulate receptors arising from parasympathetic reinnervation. However, more data is needed as the literature was limited to 2 case reports. For renal insufficiency, more studies are needed. Again, the evidence was limited to case reports. Thank you for listening to my presentation. The end. Please take a moment to follow the link for a short survey about this presentation. Again, thank you for watching.